Okay, welcome back to the channel. We're going to go over chapter 6 today. We're looking at resistance exercise for impaired muscle performance. So you can read through some of those objectives. So obviously there's a ton of benefits of resistance exercise. We have enhanced muscle performance, which we're going to talk about here in just a few seconds and what that truly means. Another important part of resistance exercise, it's going to strengthen the connective tissues of the body. We're going to also increase bone mineral density. So for our patients that have osteoporosis or osteopenia, adding resistance exercise into their program is going to only increase that bone mineral density. And by increasing muscle strength, we also decrease joint stress during activities. We're going to help reduce the risk of soft tissue injury, improve the capacity for repair and healing. So a lot of times we go into what we call prehab with our patients before they go into their surgery. So as you know, we try to get their tissues as strong as possible before, and then that gives them the better capacity for healing and a better prognosis afterwards. It also helps you improve balance, enhance physical performance, and we'll see positive changes in our body composition, leading to more dense muscle tissue with lower adipose tissue. And then the two things that a lot of people always forget about are the enhanced feeling of physical well-being and a positive perception of disability and a quality of life. So the three things that you're really going to have to focus on in this chapter are these elements of muscle performance. So we're looking at strength, we're looking at endurance, and we're looking at power. So we'll talk about what those each mean here in just a second. And just remember, if we're trying to define strength, it's the greatest measurable force that is exerted by a muscle or muscle group to overcome resistance during a single maximum effort. So we can raise, we can lower, control heavy external loads, and that'll all fall into the category of strength training. And basically, just for, kind of just a starting point, we can do around 3 sets of 10 repetitions. The key thing here is that we're trying to do moderate loads. So about 70 to 80% of somebody's max effort, essentially, or the intensity. So a one repetition maximum. We're going to do about 70 to 80% of that is kind of what we're hoping for here. Yeah. So that'll give us plenty of overload to help increase strength. Now, some of the things that you have to consider with strength is the muscle grade. So MMT is a big thing, okay? We have to be able to give our patients an appropriate exercise based on their MMT score. So if somebody has a muscle grade of 3 out of 5, that means that they can do the movement against gravity, but they can't handle any other resistance. So we may need to change, if we're going to think about strengthening the hip abductor muscles, we may need to change our patient from a side-lying position where they're doing a straight leg raise up to the ceiling more to a side-lying position, and then we can add some resistance because they're not moving against gravity at that point. Okay, so strength, again, greatest measurable force to overcome an external load, single max effort, okay? We're going to start at around 3 sets of 10 repetitions, but we can always increase, decrease, volume, intensity, those kind of things. But that's typically a good starting point. That's where people typically start. Okay, then we move on to power. So power is the strength and the speed of the movement. So we calculate that using work times distance. And there's a few things that we're going to talk about with anaerobic and aerobic power. So let's get into this. How do they differ? Well, when we're using something like anaerobic power, these are short bursts of really high explosive movements. So we're taxing different energy systems essentially. And we're going to get into the energy systems in our next chapter. So this would be like your 100-meter dash. Okay, this anaerobic power. 100-meter, I'm just going to say sprint, S. Okay, versus aerobic power. So aerobic power, we're getting into the aerobic energy system. Okay, so maybe this is your, let's say, 400, let's say 800 meter dash. Okay. So we're really taxing this aerobic system after the second minute of work. The anaerobic power, we're really taxing within that first 30 seconds. And there is an intermediate power system that we use too, but those are kind of the two that we're looking at. And it's important when we're thinking of power, okay, we can either decrease the time in which we perform an exercise. So if you think of like a powerlifting competition, when they're doing hang cleans, things like that, that's not a slow movement, right? It's a very quick, explosive type movement, and that's going to increase our power output. So if we use something a little bit more related to rehab, let's take stair training, for instance. Okay, so we can perform stair training with our patients, and they can do it, slowly and just work on the strength aspect of pushing through the quads, pushing through the glutes, the gastrocsoleus, all those things. Or maybe whenever they get closer to the end of their rehab, they're running up the stairs. So we're taking that same activity, but now we're decreasing the time in which they're performing that work. And that would equal more power output. The parameters really depend on the goal though. So again, we can either increase the load, so the overall intensity, the load, so we can add weight, we can do whatever like that, or again, decrease time. And we're just thinking these are all high intensity activities. So again, decreasing time increases power output. Also, increasing the load and keeping the time the same also increases power. Then we get to endurance activities. These are basically just repetitive activities over a prolonged period of time. So everybody knows what endurance training is, right? The goal is to resist fatigue. So if you haven't run in a long time, maybe a mile is going to be really difficult for you because you're fatiguing very quickly. And in order to get a better time on your mile run, you have to continually do more mile runs, right? You're going to eventually build up some tolerance and resist fatigue better, and that's going to allow you to perform better and run faster and get a better time. So for our parameters for endurance, we're thinking this is a high number of repetitions, okay? High repetitions. But unlike power and strength where we're at 70 to 80% of our max effort, we're going to do that at a pretty low intensity. So maybe we're going to cut that back to 50 or 60% of our overall 1 rep maximum, but we're going to be performing a lot more volume. So higher number of sets, higher number of repetitions. And the thing that you want to think of here too is if you are trying to resist fatigue, we want less of a rest period. So maybe whenever we're performing strength activities, power activities, we're giving 2-3 minutes in between sets. With endurance, maybe we're doing 30-second rests. Okay, again, we're trying to tax the system here and build up some tolerance to fatigue. So let's talk about the overload principle now. So the overload principle is really important. It's kind of why we do strength training, we do endurance training, we do power training, right? We're trying to improve muscle performance. So in order to do that, we need to add a resistance load that exceeds the metabolic capacity of the muscle that we're working on, okay? So basically, in a nutshell, is if I'm trying to get stronger, let's say I'm trying to get my bench press up, okay? And let's say I want to work up to 225, okay? If I just do sets and reps at 135 with just one plate on each side, I'm really not overloading the muscle enough. I'm not exceeding that metabolic capacity, and I'm not going to see the strength gains that I want because I'm not overloading the muscle. So again, the overload principle just states that in order to improve muscle performance, we need to add a resistance that's going to overload the metabolic capacity of that muscle. So again, we need to increase intensity and volume. Those are two ways that we can really apply this overload principle. I can increase the intensity by adding more weight, adding more weight to my bar. Instead of 135, maybe I'm pushing 185, and then I'm pushing 205, and then eventually I can build up to that 225 bench press. Also, I can increase the volume. Okay, so instead of doing 3 sets of 10 at 185, maybe now I can do 5 sets of 10. So I'm taking the volume up by 20 repetitions. So those are 2 ways to overload the muscle, this overload principle. So how do we apply this in a clinical setting? Well, whenever you get into the clinical setting, a lot of times you're going to be working with patients who are post-op or post-injury, post-stroke. So we need to eventually get to a point where we are overloading the patient to achieve our goals. But we may not be doing that initially, right? We may be trying to maintain at first, build some endurance, those kind of things. But eventually, in order to reach their long-term goals, we are going to have to apply this overload principle. So we're going to have to increase the intensity. We're going to have to increase the volume of their overall output. Now let's talk about specificity of training. This is part of the SAID principle, or the specific adaptation to imposed demands principle. So what specificity of training really means is that we have to be very specific in the way that we create our exercise routines so that they actually focus on the goal that our patient is trying to accomplish. So you can see the definition here. Adaptive effects of training are highly specific to the training method employed. So if I really want to work on getting faster with my sprints, then I have to do sprint work. I have to do something that mimics my goal. Okay? If I do a mile run, it's not really going to help me with my sprints. Okay? Maybe it'll improve my endurance for long-term running and training, but I'm not working on that explosive movement or anything else like that. So I really need to be specific with my exercise routine. And that's the same for our patients. They have certain goals. They want to be able to lift objects above their head, which is perfect. That's what we want. That's going to be functional for our patients. But we need to make sure that we're actually giving them the correct load, and we're giving them these different exercises that are mimicking their goals. Okay. And then they'd also talk about this theory of the transfer of training, just stating that there is some carryover of training from one variation of exercise to another. So let's take example for, let's take strength training, for example, strength. Okay. So when we are performing strength training, we have a little bit of a carryover for endurance. Okay, so I'm just going to write this here. That's an arrow, by the way. And this is just going to stand for endurance. So when we're performing strength training, there is a little bit of a carryover for endurance, especially if we are increasing the volume of our work. Okay, so we move from 3 sets of 10 to 3 sets of 12. We're increasing the volume slightly, so that's going to help with our endurance. However, if we are performing endurance activities with that low load, that low intensity, then there's going to be very little carryover to strength or very little carryover to power. So it does work in one direction, strength, endurance, maybe power to endurance as well, but it doesn't work in the opposite direction of endurance to power or endurance to strength. So again, specific adaptations, right? That's what we're thinking of here. We need to be very specific in the way that we structure these programs for our patients. And I'll give you some examples. So again, this is just to highlight the specificity of training principle. If this is our goal over here, is to lift these really heavy objects, put them up onto these platforms here, then doing something like a step up isn't going to help. Doing something like a high jump isn't going to help that. Okay? And same for all of these images that we see here. Okay? If there's an athlete that's trying to get back to a high jump, then lifting heavy objects is not going to help. Okay, they need to be doing things that are specific to their goals and their training. As far as the reversibility principle goes, this basically just states that adaptive changes are temporary if not used for functional activities or if the patient does not participate in the maintenance program. So basically, if you don't use it, you lose it. That's what this is saying here, okay? So if we gain new range of motion and then we're not working into our strength program in that new range of motion, then we're probably going to lose that. We're not going to have any carryover effect for strength, for power, for endurance. Okay? And if we are going through an 8-week program and we're really focused on power and strength, if we, let's say, take a month off, then we are going to see some regression. It's not going to just maintain, essentially, if we are not using or continuing on that program. So there are such things as maintenance programs, and we'll talk about that a little bit with periodization of training, right? There are times where in order to not overtrain, we would want to kind of step back in our intensity and just maintain our progress. But again, if you don't use it, you're going to lose it at some point. Detraining, reduction in muscle performance begins within a week or two after cessation of resistance exercise. So this is really important to tell our patients as far as education goes. A lot of times you're going to hear your patients say, well, when do I stop this program? Do I do this the rest of my life? Like, what's the deal? And that's a good opportunity for you to educate your patients and say, well, you've put in a lot of hard work over the last 8 weeks, and we don't want to see negative results. We don't want to see anything go backwards in your progress. So yeah, you're going to have to continue to maintenance, right? Use this maintenance program, because within a week or two after you finish, you're going to start to see those negative results creeping up. Okay, so let's talk about some of these factors that influence tension generation in normal skeletal muscle. So we have these first two up here that we're going to talk about. Okay, so let's look at all these different muscle fiber types. So that's what these ones are here. So we have our type 1, our type 2A, and our type 2X muscle fibers. So type 1 muscle fibers are slow twitch, meaning that they are not going to be used as explosive or power generating, but we typically think of these type 1 muscle fibers as being kind of our postural muscles, very resistant to fatigue. So they're going to be using some of what we call our aerobic system for energy and for maintenance, keeping our posture long periods of time. Our type 2A fibers kind of have characteristics of both of type 1 and type 2. So type 2 are explosive, fast twitch muscle fibers. And again, type 2A in particular is very special because it has both type 1 characteristics and type 2. So it's going to produce power, but it's going to be more resistant to fatigue than these type 2X fibers. So it's going to be explosive and resist fatigue. Type 2X is really all about explosive power. I think the explosive, okay? Explosive. Really bad handwriting with that, but think of the X as explosive. So type 2X fibers, fast twitch, and they are going to fatigue very, very quickly. So we're going to use a combination of all of these in order to produce tension in our skeletal muscle. The other thing that's really important to think about is the length-tension relationship. So we talked about active insufficiency in some of our previous chapters, okay? And basically, when we're talking about active insufficiency, that's when the muscle becomes too short to produce tension, okay? There's no more sarcomeres to pull on in order to produce more tension in the muscle. So, excuse me, we need to have a good length-tension relationship, basically just stating that we need to create some length in the muscle in order to produce enough tension to overcome a load. So if you're thinking of like a biceps curl, a lot of people will perform the kind of like the semi-recumbent biceps curl where they're sitting on a bench that's at an incline, and they're going to let their shoulders fall into extension, and then they're going to perform the biceps curl from that position. That is causing tension on the proximal end of the biceps, and that allows for a lot of good generation of force. The opposite of that would be something like a preacher curl. where you have your arm in a significant amount of flexion and you're performing elbow flexion at the same time. Is it a good exercise? Sure, I love the preacher's curls, but my all-time go-to would be that position that we just mentioned where my shoulder is in a little bit of extension because I understand this length-tension relationship. I know that I'm going to produce more force just by putting myself in a beneficial position. Okay, now let's talk about this force output from most significant to least. So we're talking about different types of muscle contractions here. So the first one would be eccentric. Okay, we're going to produce a lot of tension force output with these eccentric movements. Then we get into isometric, and then finally at the very end is concentric. And this is usually pretty surprising to people. But if you think about eccentric movements, this is typically when we start to decelerate our body, okay, in at least functional terms. So we're going downstairs, okay, we're sprinting and we're stopping quickly. So as we are decelerating, right, our body can handle a pretty significant amount of force. We can actually handle a lot more force eccentrically than we can lift concentrically. That's why doing negatives, in the gym, if you've heard that term before, is a really popular training method, is because we can overload the muscle, thinking of that overload principle, much more with a greater load and lower the weight eccentrically. We can add much more weight there than we can just trying to lift the movement concentrically. Okay, and then with isometric, remember that this is where we don't see any muscle, or I'm sorry, we don't see any joint movement, but the muscle is contracting. So we can really, again, much like eccentric contractions, we can hold a lot of weight. Okay, we can hold a lot of weight. We can hold more than we can lift while shortening our muscles. So this is kind of why you see these different force outputs with these different types of muscle contractions. So we can use that to our benefit whenever we're walking somebody through a physical therapy session, okay? If we know that they're struggling with concentric movements and their tissues are able to handle more of a load, then we can go to something like eccentric or isometric contractions. And here's just a table that describes those muscle fiber types and their resistance to fatigue. So you should definitely look at this here. Again, type 1, type 2A, type 2X. You can see the resistance levels here. You can see the energy systems here, and you can see the twitch rate at the bottom. Okay, let's look at some signs and symptoms of muscle fatigue. So anytime that you're working with a patient in a therapy session, you always want to be on the lookout for these signs and symptoms, okay? So uncomfortable sensation in the muscle, pain is something that you're going to obviously look for, but there's times where patients will have cramping of their muscles too. If any of these happen, if you see any of these, you're just going to want to give your patient a rest, maybe move on to a different muscle group, let that muscle recover, and then you can go back to it and kind of reassess. So that uncomfortable sensation in the muscle is what a lot of people that go to the gym regularly chase. They call it the pump, they like that feeling. But just remember that we're trying to disassociate a little bit your normal gym setting versus rehab setting. We're dealing with patients who are in pain. We're dealing with patients who've had injuries, surgeries. So we want to pay closer attention to these different signs and symptoms. The second one would be shaking or trembling of the contracting muscle, unintentional slowing of the contraction velocity with successive reps. If they're compensating using these active jerky movements, or they're really inconsistent with their movements, probably a good time to take a break. If they're unable to complete the movement pattern through the full range of motion as they continue to progress through their volume of exercise, then take a break. Again, we're looking for substitute motions here. We're going to talk a lot about those in lab and how we correct those. And if they can't continue low intensity physical activity, then we're probably going to call it a day there and see how they recover. All of these things here influence fatigue, of course. So we have to consider the health status and the different systems, cardiovascular health, pulmonary health, all of those things are going to play a very large portion here. Diet and lifestyle, again, we're not in the position to really give advice on diet as a PTA, but lifestyle changes, there are some things that I've had to have conversations with patients who smoke regularly, and that's pretty tough to do at times. But for somebody like one of my patients a long time ago, let's just say for instance, would smoke about a pack of cigarettes a day, and he had just had a rotator cuff repair, and I would just tell him, well, smoking cigarettes vasoconstricts and it decreases your blood flow, and it makes healing a lot more difficult for your body. So just want you to be aware of that. And did that person stop? Who knows, right? Probably not, but it's definitely going to influence fatigue and tissue healing as well. Comorbidities, right? Somebody with COPD or some kind of pulmonary restrictive comorbidity is going to have a very difficult time catching their breath with exercise. They're going to fatigue very quickly, so they may need longer rest periods, things like that. Medications we've talked a lot about in semester 2, and a lot of the adverse effects of those medications were fatigue, were dizziness, were all those kind of things. So we really have to be on the lookout for medications that kind of raise a red flag. And then different environmental factors as well. So as we recover from exercise, okay, we're thinking of how do we structure our rest periods, those kind of things. Well, recovery from acute exercise takes about 3 to 4 minutes to return to 90 or 95% of that force-producing capacity. However, the greatest recovery occurs within that first minute, okay? So again, if you're thinking of power, strength, and endurance, maybe for power, where it's really high intensity, we utilize this full 4 minutes or 3 to 4 minutes for a rest period before we ask them to do another repetition. If we're doing something like endurance training, well, maybe we're just going to utilize 30 seconds to a minute rest. We know that the greatest amount of recovery has already occurred in that first minute, so now we can go again. And again, we're trying to resist fatigue with endurance. So yeah, all of these are going to play an important part. And again, always remember that fatigued muscles are more susceptible to acute strains, which is what I show here in this little GIF. So you can see this is Kevin Durant playing in the finals with the Warriors. He had dealt with calf strains for the greater part of the season, and eventually, right, you see this Achilles tendon rupture. So obviously very fatigued. He had probably had some micro damage going on in there, but eventually he tore his Achilles tendon because he didn't get enough rest period, okay? We're going to kind of skip past these ones here. But I will stop here just for a second. So determinants of resistance exercise, some things that we're going to really pay attention to in lab is the alignment and the stabilization. So why is alignment important during resistance exercise? Well, it's because we have to consider the muscle fiber orientation. So you're going through your kinesiology course right now, and you're getting your patients into very specific positions, and that's to isolate different muscles, okay? So it's no different than strength training, right? Oftentimes we use the same test position as the position to perform our strength exercises in. So we need to make sure that we're targeting the right muscles in order to achieve our goals, okay? We also have to think about gravity, which we mentioned earlier with our MMT scores. So MMT again. Your MMT scores are going to tell you what position to get the patient into and what type of resistance to use. Is it going to be just gravity if they have a 3? Active range of motion, kind of working that endurance or working some of that strength? Or is it a 4, out of 5, a 5 out of 5, where we're actually having to increase resistance, add some pretty significant external loads. Okay, so again, more determinants of resistance exercise. All of these things are going to be important, and a lot of these we're just going to cover in our lab setting. Okay, so let's talk about these guys here really quickly. So force-velocity relationship, concentric muscle contraction versus an eccentric muscle contraction. So let's talk about this concentric muscle contraction as it relates to the force-velocity relationship first. So during a maximum effort concentric muscle contraction, as the muscle is shortening, velocity increases, the muscle force actually, the force the muscle can generate decreases. So what we're thinking there is that the muscle may not have sufficient time to develop peak tension as we're increasing that force velocity. But during eccentric muscle contractions, as the velocity of active muscle lengthening increases, force production in the muscle initially increases, but then it quickly levels off. The initial increase in force production may be protective response of the muscle when it first is overloaded, which is an important mechanism for shock absorption or rapid deceleration of a limb during quick changes of direction. So there's different types of different types of resistance exercise that we can use for our patients. So manual resistance, mechanical resistance. We're going to use a combination of those and show you how to do those in lab. As far as isometric exercise goes, there's a few things that we just want to make sure of. One of these things here, this contraindication. So we need to be really aware of our patients that have cardiac or vascular disorders, because we don't want them to be holding their breath, performing this Valsalva maneuver. Because when our patient holds their breath and performs this Valsalva maneuver, it increases pressure and increases blood pressure for our patients, and we want to be really cautious of that. The different types of isometric exercises, again, would be muscle setting, stabilization, and multiple angled isometrics. So when we're thinking of muscle setting exercises, these ones would be something like a quad set, where we're not adding any type of resistance. Stabilization exercises, we're thinking of using multiple muscles that surround the joint that provide stability. So if you want to think of trying to provide stability at the knee, maybe you're going to perform isometrics to the quads, the hamstrings, the hip abductors, the hip adductors, because some of those do come close and cross the knee. So we'd be kind of moving around like that. And then we have multiple angled isometrics as well, which basically we're just taking a joint through portions of the range of motion and adding a little bit of isometric resistance in those movements, and then we increase it, add more resistance, increase that joint angle, add more resistance. So all of these can be really good for early phase rehab. Early phase. Okay, we're going to kind of move past this. And then we finally get into something called, open and closed kinetic chain exercise. So there's going to be certain protocols, like for ACL reconstruction, where you are limited to only performing closed chain exercise for a certain period of time, because open chain exercises can cause shearing force, okay? And that's really bad for a reconstructed ACL. But typically, when we're thinking of open chain exercises, these focus on motion at a single joint. So let's take a long arc quad, for example, or a knee extension exercise. One motion at a single joint, okay? So the knee extensors are working, we're getting extension, and that's really it. With closed chain exercise, typically we get joint compression, so these are weight bearing, okay, and are considered more functional in nature than open chain. And typically what we're going to see with closed chain exercise is that that's going to work at multiple joints. So take a squat, for instance. So as we move deep into a squat, we're getting lots of hip flexion, we're getting knee flexion, we're getting ankle dorsiflexion. So all the muscles surrounding those joints are going to be working, as opposed to something like along our quad, where we just have the quads working. And there's your exercise for open chain and one for closed chain. There's different characteristics that you can list in these tables here, so I really recommend going to check those out. Okay, so we're going to talk about the implementation of these in our lab setting. Again, some of the precautions for resistance exercise, that Valsalva maneuver, so make sure to tell your patient to breathe rhythmically so that we don't increase their blood pressure significantly. We're always going to look for substitute motions, and we're going to look for those signs and symptoms of overtraining or fatigue. Now, your patients are going to feel some of this delayed onset muscle soreness, especially if they have not been exercising frequently and very consistently. So it's good to educate your patients on the fact that they may be sore. All right. Really want this to last no longer than 2 days, though. So if it lasts more than 48 hours, then we probably overworked too much. Some other things they have to be really cautious of are patients that have osteoporosis and axial loading. That was really bad. Because we don't want to cause a pathological fracture like a vertebral body fracture. So we have to be really cautious here. We have to be careful not to place them into a lot of flexion, and especially with rotation, and especially combination of those two with compressive forces like axial loading. So you have to be really cautious with those patients. And make sure you know these contraindications to resistance exercise. Pain is something that our patients are always going to have in physical therapy, but if the exercise increases pain, that's what this is talking about here. Okay? Okay, we're going to skip past this and this. We'll talk more about PNF techniques in some of our later courses. So our textbook does a really good job of describing these. You may want to go back and look through those, but it's nothing that we're going to be held accountable for in this course. And blood flow restriction training, pretty cool. Our book doesn't cover it in too much detail, but if you're really curious about BFR, just let me know. We can always talk about this in more detail. We have some great instructors that are certified in BFR, so we can always chat about that. And that takes us to the very end of our lecture. I hope it was helpful for you. Please come on back, listen again. See you later.